Good afternoon, everyone. Just presenting a case series of post cataract surgery optic neuropathy. So, cataract surgery is the most common ophthalmic procedure, and this PCSON is a recognized entity. It is rare but serious. So, we know usual complications include corneal edema, endophthalmitis, CME, etc. And optic neuropathy is an uncommon late complication. Immediate also it can occur. For example, if there is a retrobulbar injection which inadvertently go to the optic nerve, then it can lead to. This is not that. This is here we are discussing those which happened as a delayed more than 4 month duration, and just 4 cases only, and also the outcomes between manual SACS and phaco emulsification. So two underwent SACS and two underwent phaco, and I did the surgery at a government general hospital, district level hospital, and all developed optic neuropathy more than 4 months duration. So the theories include vascular theory, toxic theory, immune mediated response, multifactorial mechanism, etc. And only very few reports exist, and they say it happens after months after uncomplicated surgery. So coming to the one first patient, 62-year-old male, had gradual painless vision loss 6 months post-op. He underwent SACS under topical anesthesia. Actually, I do topical SACS, which not purely topical, some intracameral lignocaine preservative free is also given. This saves time for me from the block, and there is nobody to give the block actually. So here this the patient, and in right eye the vision was only counting finger 2 meter. Uh, Otherwise uncomplicated surgery, PCL well centered, but there was a optic disc edema and pallor, and his visual field findings were not recordable. OCT RNF was normal. MRI brain and orbit also gave normal studies. So suspected is optic neuropathy post cataract surgery, and some oral steroids were given tapered dose, but there was no improvement. Patient was not having a systemic diseases, so NAION could be a thing, but we cannot say that it is indeed the thing. And these are other differential diagnoses. So in next patient is 80-year-old female with controlled hypertension and vision decline after 5 months post-op. She also underwent SICS. This is the patient, and there is a swollen disc, and this is the MRI report. It says some chronic lacunar infarctions in bones, but not related to this, I would say. So, and orbit also normal. So the impression was optic neuropathy post cataract surgery. We referred this patient to medical college, but they actually thought it could be an NAION, and didn't actually give any particular treatment. And we can see a sclerosis. This is a pictures after that, some 2 months after this, and there was total optic disc pallor and some sclerosis vessels. So patient is hypertensive, so could be an NAION also. That differential diagnosis there. And in patient, third patient, 64-year-old female, diabetic patient on oral medication, it was controlled, and the complaints included was a visual field defect at 7 months post-op. She had undergone phacoemulsification and topical anesthesia. So, and there was a diffuse disc edema was there. Vision was 6/60 in that eye, and visual field findings. There was an altitudinal field defect was there. Don't have the picture of that, and OCT or NFL was normal. MRI also normal. So only multivitamin therapy is, again all this was done in the referred to the government medical college. They just gave this multivitamin tablets only. There was no improvement. The other patient, 66-year-old female, no systemic illness, poor central vision after 6 months follow-up. She also had phacoemulsification, and vision in left eye was according to 3 meter. There was a discedema. She couldn't take the photo and she was lost to follow up. And so PCSON here occurred both after SACS and FACO. There is an onset which is delayed. All cases are unilateral where the surgery had happened, and the segment was quite. Maybe some few have systemic disease like diabetes, hypertension, so that could be the risk pattern. The surgery was uncomplicated, and we recognize the edema, so disc edema, but still we couldn't do much about it. And implication, surgeons should be aware of an entity called PCSON, and patients need long-term follow-up, and patient counseling is important for delayed complications. So even though it is rare, but it's very significant, as it can lead to such visual loss, and the patient may ultimately blame you and occurs in his surgery. And prognosis is guarded. This have only limited small size only, so that is a limitation. So we need a larger studies. These are references.
Thank you, Dr. Raghu. Were all these cases with fundus view preoperatively, and did you evaluate the fundus?
We have evaluated. I don't have a photo, but the fundus was evaluated, and immediate post-op and after 1 month post-op, the vision was good.
Okay. That means the vision dropped after cataract surgery, not that
Yes.
it did not improve. It dropped.
No, it improved. Initially, after cataract surgery, it was improved.
It is improved and then it dropped.
Only delayed this problem happened 4 to 6 months after the surgery.
And why do you attribute it to your cataract surgery then? 4 to 6 months following cataract surgery, the patient developed optic neuritis. Why do you want to attribute it to your cataract surgery?
Yes, it may not be that. It's like it could be just NaON, and studies do say that the incidence of NaON can be similar. Incidence can be there. So we are just, or some other reason for optic neuropathy, but we are just contributing the cataract surgery for that. But the recent entity for called PCSON, where it is immediate, happens very late and after delayed, and so such an it's really a confusing entity actually.
Actually, my thing is totally different. Actually, like I've gone through your abstract. I think you'll remember your abstract. Okay, so let us not elaborate, but you have to change the abstract, because given a chance, I wouldn't have accepted that abstract. Number one. Number two, in your abstract, you said 6 cases. Your abstract, which was submitted, which I read, says 6 cases. But this was trimmed to 4 cases. And I think second, third, fourth cases are maybe A-wide. In order to rule out, I think you have to see the fellow eye also. If the fellow eye is having a disc at risk, then it is obvious that it is A-wide. Had the risk factors also. 2 patients were hypertensive, right? All 3 are hypertensive.
Thank you.